All right, guys, we just got a couple of slides here from our earlier lecture, so I'm just going to go right back through them, try to make this as quick and painless as possible. So let's go ahead and get started. So to start, we're going to go over the just layers of the heart and the muscles that are involved, structures that are involved. So here we have the anatomy, which we have the epicardium, the myocardium, and the endocardium. These are all just the layers of muscle that are involved in contraction versus like the pericardium is more of that sac around the heart. That is like covered in WD-40, and it's mostly just lubricates it from tearing those lungs apart, because it just sits there right in the center of your chest cavity. So we have just those structures that are involved, and it has a little bit of an illustration of what an MI looks like on those muscle walls down low. All right, so we have blood supply moves left to right. Blood flow goes from a deoxygenated blood from the body, coming from the inferior superior vena cava, moving into the right atrium, out of the right atrium through the pulmonary pulmonary arteries, into the lungs, gets oxygenated, comes back into the left atrium, pumped into the left ventricles, and then out the aorta to the rest of the body. Okay, and then so we have three valves, the aortic valve, the pulmonary tricuspid, and the mitral valve. And so the way that I like to remember the valves of the heart, the two major ones, is it has two valves. As you can see there on the right-hand side, your bicuspid has two valves, and then the tricuspid has three. So tri before you bi is how it usually goes, left to right. All right, so preload and afterload. So preload, all the volume coming in from the body. Afterload, all the force being exerted to get it out of the heart and into the rest of the body. And then you have systemic vascular resistance. So that's just all the resistance that your arteries put on the heart so that you can have pressure. Really, there's hardly any pressure on the preload side. The amount of pressure that's exerted off of the capillary alveoli, or off the capillaries, is like 5 millimeters of mercury. So really low pressure system on that side, versus the afterload system is like your normal systolic blood pressure. Okay. All right. So the properties of the cardiac conduction system is really important, and conductivity. There's actually four properties, but we'll just go over these two. Excitability is the ability for these cells to respond and generate an impulse. So basically what that means is that between the excitability and the conductivity is that these cardiac cells are pretty much doing the wave, right? So if you've ever been in a stadium, as you are watching the wave go around the stadium, everybody stands up and does the wave, right? So it's kind of the same thing with cardiac cells. They're all passing this signal on to the next person to their right. So that's an important characteristic of the cell. Okay, and so these impulses travel from our pacemakers. So they start and originate from our pacemakers. So the first and most important one is always the SA node. So the point of origin for our electrical impulses that come from the heart, our action potentials, is the SA node, the top of the heart, right atrium, right there in that picture. So its primary, where it likes to be happy, rate of compulsions is 60 to 100. It will be 60 to 100. That's where it likes to stay. Okay. Well, what happens if one of our pacemakers fail? We have about 3 backups in case if our primary pacemaker fails. Okay. So the AV node, this is why they're talking about rates here. The AV node, which sits there right in the center of the heart, over by the bundle of His, right here, it is primarily involved in slowing down conduction, because we want our heart to beat in a synchronous rhythm that is conducive of hydraulics. So if the heart just all beat as one, it would get nothing done. So we need the top to squeeze first, then the bottom. So that's why our primary pacemaker is up top. So it squeezes first, sends that signal down lower. The AV node gives it a nice pause, then sends it to the rest of the heart so it can squeeze the lower portion of the heart. But anyways, the reason why it actually does take a second to get from the top to the bottom is because of the AV node. Because the AV node stops that signal for just a couple of milliseconds, and then sends it back down into the rest of the heart. Because in the center of the heart, there's like a wall of unconductive tissue that separates these two chambers, just so that there's not like a repeating loop of constantly, like they're stimulating each other, so that it's all synchronous, okay? So the AV node, if the SA node were to fail, its rate is 40 to 60. And then down to the bundle of His, it continues through the right and left bundles down into the Purkinje fibers, and the Purkinje fibers have a rate of like 20 to 40. So it's a rate that's like hardly sustainable to life. So if you are in a if you're in a Purkinje rate, you know, both of your pacemakers have failed, you know, that's a bad place to be. You need a pacemaker. All right, so again, going back over to the means of which these impulses travel, what they mean on an electro or an EKG. The SA node fires off, it discharges, it causes those atria to depolarize, then you get a P wave. Okay, that's what that looks like on the ECG. Is the SA node fires, you get a P wave. Okay, then while we're waiting for that atria to squeeze, we need a pause in our electrical conduction. That's called the P to R interval. Okay, it's paused in the AV node. It travels down that bundle of His and into those Purkinje fibers, into the right and left bundle, and then those ventricles are activated. So then we get the QRS. Okay, and those ventricles, that's what that means. The QRS, that's the ventricles squeezing. Okay, and there's a brief pause while all these chambers are filling back up. And then on top of that, we have something called the refractory period, or the repolarization period, where this T wave is now present. That's everything recharging. All those cardiac cells, they're recharging, moving all those cations back into their respective places so they can try this process all over again. Okay, so depolarization, movement of ions preceding facilitating cardiac mechanical contraction, absolute refractory period. Nothing can happen at this time. In fact, if something does happen at this refractory period, which is why we have to be so careful with defibrillating people during refractory, is that we could send them into a lethal arrhythmia and kill them. So what we do before we cardiovert people is synchronize the monitor to their rhythm. And so when we press that shock button, it will sync precisely where it needs to, which is not the refractory period where that could possibly kill them. And this repolarization, like I said, just allows all this stuff to recharge. All right, ECGs versus 12 lead. 12 lead is a very in-depth look at the heart versus telemetry is just at a glance, okay? Telemetry, 3 to 5 leads. You can take a Holter monitor home. This is what's usually on the monitor in the emergency department, on MedSurg, what tele is looking at. This is just a quick look. I just want to see what the underlying rhythm is. I don't want to go into a deep discussion about 12 lead ECG and all the nuance that goes on with that. Okay, so 12 lead, again, that is a more in-depth, very complicated look at the whole picture of the heart. What's going on here? You're looking for STEMI, you're looking for cardiac abnormalities, you are looking for QRS, QT intervals, things like that. Are they hyperkalemic? Are they having pericarditis? There are so many different things that you can look at through the 12-lead ECG. Okay, and then so this is looking at ST segments for the heart and trying to diagnose STEMI. Really what all these circles mean is that, hey, these leads are all connected to different coronary arteries. So V1 through V2, we're looking at septal versus V3, V4, we're looking at anterior, and then 5 and 6 is going to be lateral, like the lateral side of the heart. So they're all different angles that we're looking at down at the heart to see what area is affected. Is it the right side? Is it the left side? Is it on top? Is it on bottom? Is it on the back? All right, so now going into more telemetry, okay? So let's start with our process by which we are going to look at these. So we have our isoelectric line, which is the very flat line that's on the EKG that is constant, okay? That's the isoelectric line. All right, diving back into it, going through the diagnostics of being able to interpret your ECG, develop a system to identify your electrical picture. So use the same method every single time that you look at an EKG, and stick with it, okay? So here we have our paper. We have a 6-second strip that's on the right-hand side. All those little boxes have milliamps of conduction on the vertical, and then on the horizontal is seconds, is time. So as you move right, you have time. As you move up, voltage, positive or negative voltage, okay? So we have the PQRST here, complexes, our P wave that we talked about, our atria, our QRS, which is our ventricle, our ST segment, our pause before our T wave, and our T wave is our repolarization, okay? So going with that, we'll move on to the next one. So P waves, let's start our diagnostics, and let's start our method of interpretation. Do we have a P wave? Is there a P wave? Is there a P wave for every QRS? Are there more P waves than QRSs? Is the P wave upright? These are all questions you need to ask yourself every single time that you look at an EKG. Is there a P wave? Is there a P wave for every QRS? Are there more P waves than QRSs? Is the P wave upright? Ask yourself this every single time. And look at the morphology. These P waves over here on V1, V2, they're upside down. Why are they upside down? We have one over here on the right atrium, left atrium. So that's what the whole pyramid looks like. So if we only had one atrium depolarized the other atrium depolarized the other side, it would look like a hump and a hill versus this nice pyramid looking shape. We want it to look like this up at the top right of the screen, okay? All right, so the P to R interval. How long should our P to R interval be? Well, it should be no greater than one large box. So what do I mean by that? Do you see all the small boxes here on the right and then the one big box that's in there? If it's greater than one big box, then there's a first degree block. But if it's narrower than in that span of time, then that's usually a normal P to R interval. If it's right up next to the QRS, that means there's not a whole lot of delay with the AV node. But not to confuse you, we'll just go through P wave, atrial contraction, P to R interval, 0.12 to 0.02 seconds, nice, normal, and healthy. Okay, QRS complex, 0.06 to 0.10 seconds for our time. Okay, that's how long it should take our QRS to discharge. If it's wide, there may be some pathology there. So this is the next question. Is the QRS measurement within its range? Do all QRSs look alike? Are some wide? Are some narrow? Is this something that is pathologic? Is this something that's normal? So again, this EKG that's over here on the right on lead 2, nice normal P's, nice normal QRS's, and nice normal T waves are a little weird, but I think it's more illustrating. Okay. All right, so summary, measuring components of the EKG. So PR interval is always so important. QRS interval is super important. Don't let that P to R interval be more than one of those big boxes, or greater than 0.20 seconds. Should be suspecting a block if it's longer than that. QRSs, this shouldn't be greater than 0.10 of a second. There could be another type of block. There could be something called QT prolongation. This is where you would find it. From the Q to the T, if that QRS is looking real wide, then we may be having some problems. ST segment. Okay, so this one, it troubles paramedics. It troubles everyone. They're giving you tombstone morphology here. Really, if your ST segment down here on the bottom left looks like this here, there is major pathology. There's potentially a heart attack, but there's so much nuance into EKGs that it's hard to tell at times, especially if you're new to it. Hey, is this an actual MI that we're having, or is this something that's called a left bundle branch block, which looks exactly like this to many degrees, which takes special criteria to rule out. Like I said, I'm not going to bore you with that. Just note that ST segment 0.08 to 0.120 seconds is our normal range. We don't want it greater than that. And then with that, if it looks big, there could be some pathology there. All right, our T wave. So again, the repolarization, the recharging of our heart. So usually positively deflected. What do we mean by deflection? Deflection means which direction in milliamps we are going. So when we say positive deflection, that means up on the EKG. If it says negative deflection, it means down on the EKG. So if we have a negatively deflected QRS, that means that QRS is looking upside down. It's looking like it's pointing downwards, versus a positively deflected QRS is pointing upwards. Okay, so again, we have our T waves. Problems can be our on T phenomenon. Ectopic stimulus excites the ventricles during this time. Ventricular irritability, lethal dysrhythmias can happen, possible cardiac arrest. Tall and peaked negative or flat myocardial ischemia, potassium or calcium imbalances. So what they're saying is, if you're having big tall T waves, their electrolytes are probably jacked, and they are at high risk for lethal ventricular arrhythmias, because we have cations where they should not be. All right, so U waves. We have a little bit of a dip in our EKG past our T wave. So, I mean, it could be seen in a bunch of different toxicities. So, electrolyte imbalance from all the important cations, increased intracranial pressure, enlarged heart, or digoxin toxicity, which digoxin is still used, especially in the rural communities. If you see U waves, think toxin of some sort. Toxin by electrolytes or toxin by other pharmacological means, pressure problems in your head, or you have a big heart in the bad way. Ectopic beats. So these are beats just like babies, how we can have ectopic pregnancies. That means they come from outside. They are the non-followers. So ectopic beats, premature atrial contractions, or PACs. So just the atria just contracted when it wasn't supposed to, and that just messed up the rhythm, and nobody likes that. That's what that PAC, it's just pointing out there. And it's interesting too, because that when we were talking about negative deflection, that P wave is negatively deflected. So it's not really coming from the same spot in the atria than the SA node, but it's still in the atria, but I digress. PJCs, or premature junctional complexes. So it's just a beat that, somebody decided to do the wave when they weren't supposed to, and it came from the junction. PVCs, or premature ventricular contractions, are massive. They're ugly. I mean, just look at that thing on the very bottom. And they just decided to do it randomly with no permission from the SA node. And any more than 3 of these PVCs run together, we've got a run of VTAC. So we don't want these PVCs. Usually means that there's something going on with, the heart's being just irritated by something. Usually PVCs, PJCs, any of these, just heart's irritated by something. Sometimes you could just take a deep breath and that will cause a PVC or something like that. Or you drink too much caffeine. Or it could be extreme pathology. You never know. So consult your provider. All right, so PACs. Again, we went through all the causes. Just looking through that here. This is what they look like in the ECG on the right-hand side. They are just impulses that come from the atria that are not approved by the SA node, and they cause the ventricles to contract anyways. So an ectopic beat. All right, so PJCs, Same thing, just came from where it wasn't supposed to. It was supposed to come from the SA node, came from the AV node. That wasn't cool, and it's just butting in here. The thing about junctional rhythms and junctional PVC or PJCs is they don't have P waves. Sometimes they will, sometimes they won't, sometimes they get buried in the PVC or the PJC, but they will either have them inverted or they're buried. So inverted means negative deflections. They look upside down. All right, and PVCs, again, we talked about this earlier. What we have here is just this run down here on the bottom. Looks like bigeminy. So for every P wave, there's a PVC, and so not good. It's more, I think that would be more monogeminy, but I don't even know if that's a real term. Okay, so now moving on to I don't think there's anything else that we need to go over in here. Yep, so just talking more about trigeminy, bigeminy. It's just how many PVCs are being linked up with QRS complexes, because sometimes PVCs can come regularly. This is saying greater than 4 to 6 PVCs in a row, like all next to each other, a run of VTAC. They can come in runs of 2, which is bigeminy, and then runs of 3, which is trigeminy. So 3 beat, within that 3 beat system, there is a 1 PVC versus bigeminy. Within that 2 beat system, there is one PVC. All right, so we have our different tachycardias that are ventricular. So that means coming from the ventricles, from the bottom of the heart. So we have monomorphic, which means one shape, ventricular tachycardia, which means it's probably coming from the same place every single time. And that looks like monomorphic VTAC on top. Now we have polymorphic ventricular tachycardia, which means it's coming from a bunch of different places, still coming from the ventricles, but it's coming from a bunch of different places, and usually there's no pulse associated with this. Sometimes there is, sometimes there's not. That's more monomorphic. You might have VTAC with a pulse, but polymorphic, honestly, never. And then you have torsades de poids, which is twisting of the points in French, which means that we are having ventricular tachycardia that are coming from a multitude of places in the ventricles, and it looks like radio waves in my opinion, but it means it's just it's very regularly changing its frequency and where it's coming from, and torsades de poids is a lethal arrhythmia. Too many PVCs, think VTAC. All right, let's keep going. All right, so we looked at our P waves. We looked at our QRSs. Is it regular or irregular? Okay, how do we count our rate? Well, in a 6-second strip, we're able to count all the QRS complexes and multiply it. So if we were to have, say, in this strip right up here, we have 1, 2, 3, 4, 5, 6, 7, 8. So 8 times 10, so we have a rate about 80 there for ventricular rate. So you want to count the QRSs. Don't count the Ps, count the QRSs, because we're missing association with the P waves and QRSs, okay? Irregular, irregular. How many beats do we have? Down here we have the big box method, which is the way that I like to measure how many beats we have. So find a QRS complex that meets at the edge of one of these big boxes here. And then from here, we count big boxes. So if another one were to land here, another QRS, it would be 300 beats per minute. If another one were to land here in this box here, it'd be 150. If another one were to land right here, it'd be 100. So this one lands about right here. It's about 75. And that math keeps mathing. So the next one is 60, the next one is 50, the next one is 43, 37, 33, 30. It works for really regular rhythms. It has a hard time with AFib and things that are irregular. So those are a couple of ways that you can determine heart rate on EKG without looking at the numbers. All right, so now we have our sinus rhythms. So we have normal sinus rhythm right here up on the right. Nice P waves, QRSs, rates between 60 to 100. P wave is normal, 1 for every QRS complex. P to R is good, QRS is good. Sinus arrhythmia. Sinus arrhythmia is a sinus rhythm, but it is just irregular. It's not AFib. we have P waves here that are associated with these QRSs every time, but the SA node is just doing some weird stuff. And it's just not beating like a Swiss clock, like our normal sinus rhythm does. It's a little irregular, okay? Sinus bradycardia, very self-explanatory. Sinus brady means slow sinus rhythm. So usually sinus bradycardia is called if the rate is under 60. So if the heart rate's under 60, it's 59, sinus brady. Yeah, P waves, QRSs, normal Ts, everything's marching out as normal, sinus brady. And it looks like our treatment here, if we have sinus bradycardia and they are not hemodynamically unstable, atropine, 0.5 milligrams IV push. And then if that doesn't work, transcutaneous pacing. Or they will put in a pacemaker through a central line, whatever it takes. Sinus tachycardia, this is not SVT, this is just sinus tach. So you went on a run, got your heart rate up, this rhythm here, oh, yep, every single P has a QRS complex with it. QRSs look nice, narrow, and normal, and it looks regular. So I'm gonna call that sinus tach. Well, let's see how fast it is. Let's count this in this picture. 1, 2, 3, 4, 5, 6, 7, 8, 9. I bet you there's one just hiding right here, so that would make it 10. So it's about 100 beats per minute. Or you could do the big box method, 300, 150. This rate's saying it's about like 150 beats per minute. I don't think this is a 6-second strip. I think we need to go a little bit further. But beyond that, causes are fever, anemia, hypotension, PE, anything that can get your heart rate up, you're gonna get sinus tach. But if it's not, super life-threatening, sinus tachycardia is a compensatory mechanism. Just keep that blood moving around. All right, SVT. This is a life-threatening lethal arrhythmia if left untreated. Its rate is 150 to 300, greater than 150. It's merged with the T waves. You can't really even discern them. You could barely discern P waves. It's just because it's so fast. But how do we know it's supraventricular? How do we know it's coming from the atria? Well, it's narrow and it's positively deflected. If it were coming from anywhere else, like the ventricles, then it would be really wide and it would be, it would just look fat and ugly versus like, if it's from the atria, you have these nice narrow QRS complexes that are positively deflected, okay? So causes, electrical pathway disruption, stimulants, medications, heart conditions, dehydration, fever. You're gonna get palpitations, you're gonna get chest pain, restlessness, anxiety, pale, cool, diaphoresis. Treatments is they'll be doing some vagal maneuvers, so they'll have you blow on a syringe, they'll splash your face with cold water, they can use beta blockers, calcium channel blockers, ablation if it's super, resistant to all these treatments, and adenosine, adenocard. What this does, blocks the AV node. So there's no more impulses coming from the atria, okay, until you guys can figure out your stuff. And then that usually works. These SVT rhythms, by the time you're cracking open the top of these adenosine vials, they decide to calm right back down. So not super resistant, but if they need shocked, prepare to shock them with a lot of joules, because atrial dysrhythmias need a lot of energy to stop. All right, so AFib, it's the hallmark to AFib is irregularly irregular. So the atria is actually just quivering. So fibrillation means quivering, really. And so what's happened is the SA node has failed, and the whole atria has decided all at once that it wants to become the SA node. And so every single person in that stadium is standing up and sitting down all at the same time. And there is no logical or good rhythm happening in the atria. So the AV node is just kind of letting these impulses in through random, and it's looking very chaotic, and it's getting beats wherever it wants. And on top of that, when it's fibrillating, it's just quivering. It's not pumping blood very well doing that, so it could accumulate clots in there. So you got to be careful with reperfusing these people and getting those atria to squeeze again, because they could throw a lot of clots. Everything else usually looks normal QRSs, T waves. They're there, but they can get hoovered into other QRSs. The thing is, it's just, if you don't see P waves and it's irregular, assume AFib. Okay, and AFib is just a hallmark of a tired heart. If your heart's tired from all these different risk factors, you're probably going to have AFib. Complications, like we said, we have thrombolytics, agents that we need to give these people. They aren't filling their ventricles very well. They're not moving blood around. Again, you can get clots that just build up in the atrial chambers. And so, yeah, they're at high risk for throwing those. And then the treatments are, of course, blood thinners, digoxin, diltiazem, beta blockers, electrical cardioversion ablation, or a maze procedure. It just depends on how well you're able to tolerate the AFib. So A-flutter is different from AFib because A-flutter is very regular. It has a shark fin morphology to the P waves. And so as you can see this, not shark fin, sawtooth pattern. If you're seeing a sawtooth baseline, think A-flutter. The atrial rhythm is just going way too fast. These P waves are not conducting for every QRS. And so really what needs to be happening here is that we need some medical intervention so that we can slow down this rate, because like I said, this atria is freaking out, going way too fast, and it's causing everyone else to follow suit. So slow them back down, and then also they're not discharging all the blood that's inside of the atria. So again, they're also high risk for clots. AV blocks, so atrioventricular blocks. We have many types of degrees. So right now we'll start with the first degree. So we talked about the box method. So if the P wave has at least one full big box in between the QRS, you've got a first degree block. So up here we have an example of first degree block. It looks like we have one full block and some change. So yeah, first degree, I have one. Sometimes it's benign. Most of the times it's benign and asymptomatic, so I never really have any problems with it. So P to R is good, QRS is good, just the P wave's really far away from the QRS. All right, so Mobitz type 1, so Winky Bach, so a second degree type 1. So it gets a little confusing with the types and the degree blocks. So type 1, Mobitz, or the second degree type 1. So Winky Bach, wider drop. The P to R intervals is progressively getting wider with these 3 beats, and then the 4th beat has been dropped completely. There is a P wave, but no QRS associated with it at all. There is no QRS. He didn't show up to the party at all. He missed it. So causes ischemia, hypoxia, digitox. We have electrolyte imbalance. If they're symptomatic, give them 0.5 milligram of IV push atropine or temporary pacing, if that's what doc wants. On top of that, morphology all looks good. It's just that these P waves are getting farther away from their lovely QRSs. Okay, type 2. So this is different from Winky Bach because the problem is, we have the progressively longer P to R interval, right? Well, this one doesn't do that. It just drops randomly. You have PQRST, PQRST. The P to R interval looks great. It's fine. But then just randomly every now and again, we just lose a P wave. Yes, it is also a life-threatening condition if this progresses and these Ps no longer become associated with these QRSs and everyone's just doing their own thing. The top of the heart is not talking to the bottom. We have a problem because our ventricular pacemaker rate is only 20 to 40. That's not fast enough to sustain life. So type 2 Mobitz, again, P to R interval is fine. It's just the QRS drops every now and again. So that's what differentiates type 1 to type 2 second degree. Type 1 is longer drop versus this one is beat, drop. So moving on to third degree blocks, complete heart block. This means that conduction barrier that's in the middle of the heart where the AV node likes to sit, Well, that got cut off somehow, and now the top of the heart cannot talk to the bottom. And so you have the atrial rate taking along 60 to 100 as normal, and none of these messages are getting through to the ventricles, and the ventricles are sitting there twiddling their thumbs, wondering when these messages are going to come in. They start doing their own thing. So they're like, okay, well, if the atria is not going to tell me to beat, I'm just going to beat on my own the only way I know how, which is 40 to 20, which is too slow, which is why this is a life-threatening heart block. Atropine doesn't work because that's it does something to the vagus nerve, which causes the heart to beat faster, and we don't have there's a disassociation with the vagus nerve on the ventricular side here, so it's not going to work. So what they need is pacemaking, or a pacemaker of some sort, and it usually comes from an outside origin or medical intervention. So we'll either pace them, or they need to go see a cardiologist, have a pacemaker put in. Like I said, life-threatening condition. Ventricular VTACs, we already talked about VTAC, can go into VFib. It's fast, 100 to 250 beats per minute. P to R, not even measurable. There's no P waves. The QRS is super wide, greater than 0.10 seconds, and overrides everybody. This yells the loudest, and whoever yells loudest in the heart gets to be the primary pacemaker. And so we don't want to leave this patient alone. We want to call a staff assist or a code blue for a patient like this. Causes, here are all the causes up top. Treatment, if they're pulseless, ACLS. If they have a pulse, antiarrhythmics, and treat the cause, cardiovert, shock them if you need it. VFib is different. So when we talked about fibrillation, we talked about quivering. So this means that the ventricles are quivering. And is that a very good way to pump blood around? It's not ideal. So it actually pumps no blood, and they're usually always pulseless. There is no perfusion, no pulses. It looks like just a fine, coarse line on the isoelectric line. It's chaotic. Everybody's trying to become the primary pacemaker, and no one's listening. And it's a life-threatening condition. So VFib, nice and fine. All right, idioventricular rhythms. So this is where the SA node has just given up. We have no P waves. SA node is cooked. He's left the chat. The ventricles are just trying their darndest. They're giving it the best community college try, and they can't, because they can only beat 20 to 40 beats per minute in a nice regular way. It's a dying rhythm. Usually the patient's about to code on you and is in complete cardiac collapse. The way that you can tell this is different from like sinus bradycardia is like, one, it doesn't have P waves, and then two, it's super slow, 20 to 40 beats per minute, and it's wide. I mean, look at how wide these QRSs are, and there's that T wave at the very end. So not very compatible with life, at least not for long. Again, here are all the causes. Here are the treatments. A lot of times ACLS involved and or pacing. Asystole. So asystole is the most stable rhythm in cardiology. Once it starts, it usually never stops, and it will continue to always be that way. It is where there is no electrical conductivity in the heart at all. Nobody's doing anything, neither the atria nor the ventricles. It is a flat line. And can you shock this? If you know ACLS, you mean the answer is no. There's no shocking asystole because there is nothing there to shock. Again, they're over here trying to consider your H's and T's: hypoxia, hypovolemia, hydrogen ions, hyperkalemia, hypothermia. Yeah, you just treat them with CPR, try to treat underlying causes, give them epinephrine. But usually they're not coming out of this. It's a pretty lethal arrhythmia. PEA, which is pulseless electrical activity. This is just any sort of rhythm that's happening within the heart that doesn't have a pulse associated with it. I mean, technically, you could argue and say that VTAC is a form of PEA if you don't feel a pulse with it. But VTAC is still VTAC. But if it looks normal, like sinus brady, idioventricular, anything, and they don't have a pulse associated with it, it's PEA, so pulseless electrical activity. If you have any electrical activity and you have no pulse, PEA. Cardioversion defib in ablation, cardioversion electrical discharge on the R wave, joules 50, 100, 200. We actually use 360 in Southern Colorado on the ambulance. Just give them the one and done. Don't mess around. Just thwack them with as much as you can so you don't have to end up shocking them again. Again, it's important to sync, hit your monitor to sync before you administer that shock. Otherwise, it's not going to go so well. Beyond that, ablation will burn irritable focus on these tachyarrhythmias, so like AFib, A-flutter, things like that, that will burn these electrical pathways that are causing this absolute chaos. And hopefully it synchronizes the entire heart. But yeah, they go and burn in those electrical pathways. All right, drugs for cardiac arrhythmias. So we have our antiarrhythmics, so chemically slows the heart rate. So we have adenosine and amiodarone. Adenosine, Adenicard, which is a chemical cardioversion, which like causes a block of the AV node and totally stops the heart for just a couple of seconds, and then it restarts it. Amiodarone, ventricular antiarrhythmic, where it just slows those ventricles down. Anticholinergics increase SA node stimulus and increasing heart rates, like atropine. Also, atropine has a direct correlation to the vagus nerve. The nerve innervates the heart, and it also allows the heart to slow down. So it's basically constantly giving the brake pedal response to the heart. And atropine just takes the foot off the brake pedal and allows the heart to go to a heart rate that it's normally not permitted to do. And that's how you increase heart rate. Anticoagulants, Coumadin, heparin, and some other ones that I have no idea how to pronounce. I know apixaban, which are great for inhibiting clot formation, which could kill your patient. Beta blockers, so beta 1, so slows heart rate down, decreases workload, O2 demand, atenolol, metoprolol, carvedilol, statalol, so sotalol. All sorts of beta blockers that we can use. Calcium channel blockers conduct through the AV node, decreasing heart rate. Diltiazem or cardizem. I think amlodipine is also a calcium channel blocker. It works great. Cardiac glycosides, including digoxin, slows conductivity through the AV node, decreases heart rate, and improves contractility, which is through Frank Starlink's law of the heart, which is its own like complicated lecture. But the heart is a rubber band. Digoxin allows that rubber band to become more rigid. Vasopressors, which is either we're supporting the venous or the arterial side or the pump problem. We're increasing pressure somewhere with a pressor. Okay. Here we go. We have some more practice with administering meds, which I think you guys know. Assessing the vital signs every Q4 hours, monitor for dysrhythmias, more nursing implications of which we should know. More things for that, and I think we are good. And if you guys have any questions for me, please reach out, and I'd be more than happy to go over anything else on EKGs. Thank you guys for watching.